Hello, everybody. My name is Michael Harvey. I'm the Information and Privacy Commissioner for Newfoundland and Labrador, and I'm very honored to have been asked to moderate this session on governance and interoperability. These are topics which I've had the real privilege to be discussing with very interesting and educated professionals as part of the expert advisory group on the Pan-Canadian Health Data Strategy over the recent months, and I'm very happy to be with one of them, Ewan Affleck, here today, and of course others. I will not belabor things and eat up our very valuable time by giving lengthy introductions, but I will give very brief introductions. Our panelists today are, and in the order that they will speak, Mohammed Mandami. Mohammed is the Vice President, Data Science and Advanced Analytics for Unity Health Toronto. He'll be followed by Katie Gibson. Katie is the Vice President, Strategy and Partnerships for the CIO Strategy Council, and finally, as I mentioned, Ewan Affleck, who is the Senior Medical Advisor for Health Informatics with the College of Physicians and Surgeons of Alberta. So that's our panel for today. Each of them will speak briefly, and then we will have an opportunity for discussion. So without further ado, I'm going to turn things over to Mohammed. Great.
Thank you very much. It's a pleasure to be here, everyone. I'm going to start off with a case. We don't have that much time, so I'm going to try and go a little bit quickly. Mr. Smith is what I'm going to be talking about. He's a 72-year-old male in British Columbia who's currently being managed for diabetes and has several comorbidities, including congestive heart failure and rheumatoid arthritis. He has a primary care physician and 4 specialist physicians. Now, Mr. Smith has been hospitalized multiple times over the past 5 years for a variety of reasons at different hospitals and is at risk of having his foot amputated. He's currently visiting his daughter in Ontario and was just hospitalized at Health Sciences North in Sudbury for worsening heart failure. Now, the medical team at Health Sciences North has formed an initial assessment based on multiple diagnostic and lab tests, as well as patient history from Mr. Smith and his daughter, who's accompanying him. However, unfortunately, the medical team is not able to access Mr. Smith's medical record in British Columbia, because now he's in Ontario, and a record of his hospital stay at Health Sciences North will not be transmitted to his primary care physician in BC. Further, neither Mr. Smith nor his daughter are able to access his health records efficiently to meaningfully engage in his health care. It's not exactly a very uncommon situation where clinicians in different groups or organizations can't access the records for their patients that they collectively see, which really does kind of hinder healthcare, its efficiency and its effectiveness. One of the key issues to understand, though, is the provision of healthcare in Canada is mandated nationally, but it's managed jurisdictionally. So it's the provinces, the territories, and some federal populations that actually manage the delivery and therefore collection of data around the healthcare that patients and the public receive. There's lots of variations in models of healthcare delivery, technical infrastructure, and legal and privacy considerations that exacerbate this complexity. Within each jurisdiction, there may be considerable variation between healthcare providers and institutions in the way they capture, store, and transmit data. So first of all, what are the sources of data? Well, hospitals, that's one. Each hospital has a different IT setup, and they have different electronic patient records with different vendors and different standards. Outpatient clinics is another source. Now, outpatient clinics, many of them also have different electronic medical records that often don't talk to each other. And then there's also facilities that are outside these settings, lab facilities that use lab information systems, pharmacies that use pharmacy information systems, medical imaging facilities that use radiology information systems and picture archive communication systems, and the list goes on. So it can vary considerably. For example, different labs may use different reagents. Medical imaging machines may be very different from one place to another, and they don't have the same protocols and don't really talk to each other very well. And then, of course, there's wearables, smartwatches, smart rings, those sorts of things that we're seeing more and more people use. And just to highlight this problem, in 2021, Canada Health Infoway did a national physician survey and found that nearly 90% of physicians use an electronic medical record to enter or retrieve patient clinical information. However, the EMR vendors vary greatly, with no single platform being used by more than 17% of physicians. So this highlights a critical interoperability challenge. Moreover, only 60% of physicians use electronic ordering for lab and diagnostic tests. Only 57% receive hospital visit and discharge information electronically, and only 49% receive automated warnings for potentially harmful drug interactions. Only 37% use electronic referrals to request specialist assessments, and only 10% have an online option for patients to request prescription renewals. Only 2% have access to advanced analytics technologies to inform clinical decisions. Clearly, there's lots of room for improvement with data and with information technology. In the example that I used with Mr. Smith, he's being cared for by 4 specialist physicians in British Columbia. Each of them use a different electronic medical record for capturing information, and they have all different structures and formats. None of these EMRs are being widely used in Ontario. This variation poses challenges for data entered in these electronic medical record systems to be shared across providers and institutions. And as a core example, clinicians often don't use consistent terminology when entering data into an EMR. For example, a heart attack could be a myocardial infarction, could be acute coronary syndrome. There's also ways to code this. So how do you convey that information in a structured, standardized manner? So to achieve a pan-Canadian vision for better use of health data for Canadians, we need an overarching national digital health data architecture enabled by compatible, interoperable health data systems and seamless access, privacy, and security provisions with aligned legislation and governance structures. That's a lot to chew on. That's ideally what we would need to have. And I think interoperability must facilitate the timely availability of meaningful data that is fit for clinical, personal, and analytical uses. It's just a couple of other points. What is health data interoperability? I haven't really provided a definition yet. So it can be defined as the ability of diverse information systems, devices, or applications to connect, exchange, and cooperatively use data among stakeholders to optimize the health of individuals and populations globally. Again, that's a pretty technical definition, but basically we want data to talk to each other. That's really what we want to happen. The benefits of interoperability are great, from providing more effective care to improve patient safety, improve accuracy of medication information, reduce duplication of things like lab tests and radiology tests. I'm sure many of you have went to one hospital and then went to another institution and you had the same lab test done. Why are we doing that? Well, it's because a lot of our systems don't talk to each other and we simply didn't know. So what can we do about this? There are standards development organizations, or SDOs. For example, the Health Level 7 International Organization, or HL7, and the Integrating Healthcare Enterprise, IHE, that specify health IT standards for their use across the system. There are over 40 SDOs, or standards development organizations, in health IT. So there isn't a shortage of these things. For example, the HL7 version 3 Clinical Document Architecture, or CDA, is an XML-based document markup standard that specifies the structure and semantics of clinical documents for the purpose of exchange between healthcare providers and patients. It defines a clinical document as having specific characteristics, things like persistence, stewardship, potential for authentication, context, wholeness, and human readability. There's a lot of thought that goes into these. And the consolidated CDA, or CCDA, is a library of CDA templates. Now, if we go one step further, an emerging standard for the communication of digital health data between entities is HL7's Fast Healthcare Interoperability Resources, or FHIR, which defines approximately 140 common healthcare concepts or resources that can be accessed and exchanged using modern web technologies. So while standards like CDA and FHIR provide a foundation for our digital health data structures and set standards for the transfer between entities, the semantic level focuses on medical terminologies and nomenclatures and ontologies. So it's a challenge because there are over 340,000 medical concepts that need to be standardized. For example, the term myocardial infarction, as I mentioned, can also be referred to as a heart attack or acute coronary syndrome or even ischemic heart disease. Terminology standards aim to standardize healthcare features into common standard terms that can translate across individuals, institutions, and healthcare systems. So the more general systems are things like the system nomenclature of medicine, clinical terminology, or SNOMED-CT, which is a standardized international multilingual core set of health terminology. It can be complemented by domain-specific terminologies, such as the identification of medicinal products, or an IDMP, for medicines, or for another example, logical observation identifiers, names, and codes, or LOINC, for laboratory medicine. There's also overarching models. So the Observational Medical Outcomes Partnership, or OMAP, Common Data Model integrates different terminology standards. This approach transforms digital health data into a common format, as well as a common representation of terminologies, vocabularies, and coding schemes. And OMAP is emerging as a person-centered data model in many healthcare jurisdictions around the world. So I'll close here by basically saying that there are data standards and interoperability frameworks, and they're evolving and maturing. But in Canada, we haven't been very good at adopting these standards in a uniform, consistent manner. And that's where I think a lot of work needs to be done. And there's lots of considerations at the organization level, legislation, policies, governance processes to enable health data interoperability among a large network of entities for seamless flow and availability of high quality standardized health data to advance clinical care, health policy and systems planning, research, and public engagement. And this is what really needs to be done. And we need to aspire to a holistic approach that involves not only technical expertise, but considerations around privacy and security, deep clinical patient public engagement, and of course, solid governance. In the interest of time, I'll end there and hand it over to the next speaker. Thank you.
Thank you very much, Mohammed, for getting us going. I'm going to hand it straight over to Katie to keep things flowing.
Great. Well, thanks so much, Michael. I'm really delighted to join you and my fellow panelists in this conversation. And thanks to Mohammed for diving into the standards landscape. Really comforted that this audience is one of the few that won't be scared off when we start talking about standards. Because all of you know that they play a really critical governance role alongside legislative and regulatory and other tools. So CIO Strategy Council is a Canadian nonprofit. We're focused on Canada's digital transformation. And as the name would suggest, we bring together the technology C-suite from across all sectors to converge on common digital priorities. We are a standards development organization accredited by Standards Council of Canada, and we focus on data and digital technologies. The reason we do that is we recognize that technology innovation moves faster than our ability to regulate it. And standards can really provide those needed guardrails on the digital economy, and they can fill that gap when there is a lag, especially when they're developed, with an accredited consensus-based process, and are something that can really stand the test of public scrutiny. So we have standards on data governance, AI ethics, cybersecurity, digital ID, credentials, and we also have verticals, and we have, seen a growing need and have gotten more and more involved in healthcare standards and health data standards. The reason for that is very pragmatic and practical. We've seen that the pandemic has put the healthcare system under unprecedented strain. We've seen, Canada's ability to quickly gather and marshal health data. There are real gaps that have become quite evident. And I think, we're seeing this emerging consensus that Canada really needs a more robust framework for securely gathering and exchanging health information, while also, very diligently protecting individuals' rights to privacy and control over their data. So exactly the kind of overarching framework that Mohammed was describing. So I won't dive into all the details, but just, sort of high level in terms of some of the initiatives we have underway. We're developing a national standard for health data and information capability framework, which helps guide health organizations in collecting, using, and storing and distributing data. We've partnered with Health Standards Organization. When the pandemic struck, we actually had a very urgent request from stakeholders and approved quite quickly a standard relating to the responsible collection and use of digital contact tracing and monitoring data in the workplace. And that's certainly something we can do, as the need arises, we can mobilize quite quickly to create standards that help out Canadian organizations. In terms of data governance, we have quite a few data governance standards, and those cut across all sectors, including the health care sector. So, the work we do on ethical design and use of automated decision systems, the work we do around third-party access to data, all of that is very relevant as data and as AI ML are deployed in healthcare. So, I just end by saying we continue on digital ID, cyber resiliency in healthcare, health data, all of these areas. We have ongoing standards development work in partnership with groups like CIGI and SHIMA and Healthcare Can. Really delighted to have these broad sort of sector partnerships to make sure we're getting all the right folks around the table to really use our consensus-based and accredited process to get the best standards out there. Thanks.
Thank you very much, Katie. Okay, Ewan, over to you.
Thank you very much, Michael. I have a few images that I'd like to share, so I'll try to do that. And you guys can confirm, do you see that,
Yep.
that individual? Okay, well, thank you very much. And I'm really gonna build on what Katie and Mohammed have said, and a lot of excellent discourse on the necessity for standardization. I'm gonna do this through telling a story basically about an individual, much like Mohammed. So, and propose to that the basic unit of information in Canada needs to be the individual, the given person or the recipient of care, the beneficiary of care. So the first thing to understand is what the role of information or data is in health service. So you have a provider on the left and a beneficiary or a patient on the right. And healthcare is a relational industry. So this relationship occurs through a discourse between, at the most discrete level, between these two sets of individuals, right? And there are many forms of information that can be exchanged. We, on the top level, we listen to history, we examine individuals, we talk to other experts in the field, we talk to family and other caregivers, we have stored data around logistical data, appointment times and so forth. We have DI, we have medical records, we have laboratory, we have clinical decision support tools, many digital now, but historically textbooks. We have all these forms of information, and we exchange them in the course of care at the most discrete level, and it informs the quality of service that we can provide. So if you get rid of those forms of information, either some of them or all of them, ultimately, if you get rid of all forms of information or data that we use in the current course of care, care vanishes. So the raw material, the currency of all decisions made in healthcare is information, right? So there's a negative imperative if, as Mohammed and Katie have said, if you are unable to access some of those informations, as the instance Mohammed provided where someone travels, or if there are legislated reasons that suggest you shouldn't be exchanging information, then this negative imperative or this inability to share information becomes a problem and can result in what could be called informational harm. So informational harm is harm that is accrued to an individual through either inaccuracies or inability to access their information to provide them care. And the likelihood of any of us making a decision, making an error or a misinformed choice in the care we provide, it increases with the lack of integrity of information we have. So there's also the notion of a positive imperative, something that compels us to share information. And this would take two principal forms. One is we build interoperable systems that allow it to occur. And the other is that we compel ourselves to share information in order to assure the quality of care in Canada. Now, as Mohammed has just stated, and Katie implied with theirs, the standards that they're suggesting, this positive imperative, we haven't done a very good job of putting this in place in Canada. We largely have the negative imperative in place. So let's talk about one other form of information exchange that has to happen. So I talked about the discrete individual care. Well, the care the data that is accrued from any individual care also can be pooled, as we see on the right, with the data from many other people. And this collectivization or pooling or aggregation of data can inform our decisions going forward, right? And so our ability to share the data and consolidate it or pool it informs research, population health, management, education, the development of clinical decision support tools, so on and so forth, right? And so there needs to be a positive imperative to do that as well. And again, we have suffered with both of these, our capacity to share information that follows the patient and our capacity to share it and pool it in a manner, in a standardized manner that actually makes that information usable. So if we look at this then, a specific example. So we have an individual who's a patient, and this is sort of like rephrasing Mohammed's story. In a little town called Rainy River in Northern Ontario. I used to be a clinician in Rainy River in the 90s. And the patient travels to Thunder Bay. And so I won't go over this in great detail, but the patient travels there. Of course, these two red dots, the health service in Rainy River, Northern Ontario, and the health service in Thunder Bay are on different systems. These are not interoperable. And so the information is lost because the individual didn't know they were going to be in Thunder Bay when they needed to go to the emergency room. And therefore, there is a chance to promote informational harm through disintegration. I would call this legislated health data damage. So each of these red dots are custodians. The custodial framework is the framework used in Canada that says the people in charge of the health data who are who have the obligation before law to protect that and ensure its privacy also have the power and historically to choose the systems upon which they collect and in which they store the data. So custodians or health services, and these are physicians, pharmacists, health authorities, so forth, historically have largely selected different health information technologies that effectively result in data fragmentation. The second issue is that there's a negative imperative largely in place to share data across these systems based on the legislative framework around privacy. Now, there's nothing wrong with that framework as such. The problem is that there is no positive imperative, and this is what Katie and Mohammed have just said. We've done a very poor job balancing our approach to data, whereby we say, you know, you need to protect it, need to assure its the security of this data and the privacy of the data, but you do have to share it at times in order to assure the well-being and the health and the quality of care. And so the positive imperative legislatively in Canada is largely absent. So if we then move this individual to Winnipeg, across a border from Ontario, we run into a whole set of other issues, and that is that the governance of health data, and this was referred to by my colleagues here, because the health data governance is fragmented in 13 ways in Canada, there is non-aligned legislation, policy, regulation, technology, and workflow. And so specifically, we have 13 different versions of custodial legislation, health information through health information acts and so forth. So this adds a whole other layer of chaos to this environment that on an individual basis is impairing the exchange of information necessary to avoid informational damage and harm to Canadians who are seeking health care. Lastly, if we look then at the consolidation of data, and remember we want to pool data, there are two means to achieve data benefit to Canadians. That's through their individual health information, following them through the course of their care. And the other means is by collecting the data from different individuals, pooling it, and gaining insights through that. Because of all this governance and custodial fragmentation, our capacity to do that, and we've seen that through our response to COVID, we see that in almost every way, is limited. So if we want to have insights into cancer care, cancer research, COVID, whatever, we are struggling to do so in a meaningful way because of the fragmentation through governance and legislation. So this has impacted both individual care as well as research, population health, management, education, and other forms of data insights from pooled data. So the question then, so really what is happening in Canada through governance and legislative, we have governance and legislative health data damage occurring because our governance and health data models are old analog precursors that have not been modernized for a digital age. And this is resulting in informational harm, both for individuals and for populations in general. And so we need to, frankly, reinvent ourselves around a coherent governance and legislative model that is actually a digital age model. And why do we need to do that? Why do we need digital age governance and legislation? Well, it's self-evident. And the way to achieve that is through patient-centric data architecture. So if we build a data architecture that follows an individual longitudinally over the course of their entire care, this should achieve our goals. And again, we have a service-centered or custodian-centered data architecture currently. And so the 4 reasons this is necessary, first of all, there's a legal imperative. In 1992, the Supreme Court of Canada, through the case McInerney versus McDonald, established that patients or individuals should have access to and oversight over their health information. Not necessarily the physical embodiment of that information, but the content of the information belongs to each and every one, all Canadians. The second is a quality imperative. There is work being done and evidence that is beginning to be accrued that if individuals have access to their data and their whole data, then their quality of care will improve. And certainly around efficiency and safety, this is becoming evident. There's a recent study in the British Medical Association Journal on this. There's the data imperative. If we build systems, and this is an important concept, if we build person-centric data architecture where the data follows the individual over the course of their life, this obligates different custodians and different governments and different jurisdictions. It obligates them to align policy, workflow, governance, and legislation around a common harmonized model. And that is essential, as my 2 co-presenters have just said. So it will standardize our approach. The patient-centric model obligates that. And lastly, I would suggest there's a moral imperative. And the moral imperative is this is absolutely the right thing to do, because if we don't do it, we will continue to compromise the care of Canadians, both on an individual and population basis. So how do we achieve this? And this is my last statement, or my second. First of all, we refer, and yesterday in the discourse, there was people refer to the Constitution of Canada, which separates the powers over health service presents in no way a barrier to optimize digital architecture in Canada. The Constitution does not mandate a fragmented policy approach. There is nothing stopping us from harmonizing our data approach, our data architecture, our legislative and policy architecture. The only thing obstructing us from doing so is political will, literacy around defining what the problem is and our need to rectify it, and imagination. So lastly, how is this achieved? Well, we need, and this is sort of some scoops coming from the Pan-Canadian Health Data Strategy, the third report, which will come out soon. But we should base this work on a principle-based charter of health data. There are design principles around coherent data design and architecture that should be established and ratified by all parties. And those parties in the second bullet are the federal, provincial, and territorial governments, but very importantly, also First Nations, Inuit, and Métis who have data sovereignty. So these are the oversight bodies that need to be engaged to approve a charter that is an agreed upon statement of principles of data design based on our obligation to deliver quality care and uphold the charter, the Canada Health Act. The oversight of this group needs to be competency-based. This is complex, not representational, and it should be appointed. There needs to be substantive public and patient empowerment and involvement in the oversight of this process. That is our ultimate accountability, and there are many patient advocates in this domain who are exceedingly knowledgeable and informed about this, and that knowledge needs to be leveraged. We need to further leverage existing knowledge and expertise and best practices. Yesterday, you heard about international federated models to achieve data integration in the European Union. And there are also C commissions or C organizations in Canada with such as CIGI and InfoA and so forth that have a lot of knowledge around this. We need to leverage this expertise. It's not a lack of expertise that is impairing us. We need to ensure that our health sector is literate, both the public and the health sector, and that includes people in positions of health leadership need to be literate about the issue in order to set legislative and policy models, public policy that works. This needs to outlast electoral cycles and capital funding cycles. This is at minimum, probably a 10-year process to reinvent and reimagine a digital age architecture that is necessary. And the process needs to be incremental and iterative. We need to fail fast when things are not working, and we need fundamentally to build trust among all the proponents. So thank you very much. I'll stop there and unshare my screen and turn it over to Michael.
Thank you very much, Ewan, and also Katie and Mohammed. You've done a great job of sketching out really the challenges in front of us that largely arise from fragmentation. And that fragmentation, I think you've described it in a way that I think helps us understand. I mean, anybody who's been touched by the health system in this country can, I think, appreciate, some maybe more than others, it's the incredible complexity that comes from just the provision of clinical care to so many millions of people, but also the complexity that arises from our federation, which and our constitution, which provides that healthcare services are delivered by the provinces and territories, which is something inherently good about our system, because it provides for more responsive provision of healthcare services, but also creates consequences when it comes to such things as the provision of services across jurisdictions, or in our instance, primarily the sharing of data. So you've sketched out the issue, and standards are a major part of the solution. Standards, both with respect to interoperability and governance. And so this discussion, I think, flows very nicely from the discussion in previous sessions during this conference. I'm going to get to questions that have been submitted previously. I would also note that please provide your questions in the chat. I'm keeping an eye on the chat myself, and there's a crew at the University of Waterloo who are feeding me things as well. But while you have a chance to chew on that, I'm going to take the opportunity to ask my own question. And that is, and really I'll most directly focus on something that you said, but also that flowed through from the previous sessions. There's been a lot of talk over the course of the day about the balancing between openness and transparency. You talked about a negative and a positive imperative. And I could say that I came to the expert advisory group as a privacy commissioner. I certainly didn't come to say, well, you know, we should share more data, and but maybe we're taking privacy too seriously. Maybe we should take it less seriously, and share more data. So I didn't come here, and I don't think I have to say we need to take privacy less seriously. I don't think that we're talking about a zero-sum game here, where we can improve the extent to which we use data by giving up on privacy. I don't believe that. I believe that there's a win-win here. And so I want to ask each of you, what do you see as the way to win-win? So how can we improve openness without sacrificing privacy? I mean, the roots of, I think that the roots of what of the answers to that are in things that you've already said. So I'm just, I think, framing things in a slightly different way to emphasize the win-win here, but I really think they're there. Anyone want to jump at that first?
Sure, maybe I'll take a crack at it and get us going. Maybe I'll use a bit of a case example. And I'll start maybe by kind of backing up and saying, what are the uses of the data to begin with? I think few people would argue that if data is being used to provide care for patients, those who are providing care really should have access to that data. And that is identifiable data because you need to know the person who you're managing. So I don't think that privacy is as big of an issue there. And I think we have established as a society that is acceptable. Where we get into things that are a little bit more tricky are areas of research, policy analysis and such, where I do think there could be mechanisms created where we do have use of data that are that adhere to privacy and security principles, that have de-identified data for researchers, for example, and that are controlled to a certain extent, that enable that. Where some of the tension comes, at least in my experience, is when you try to bridge both. So the example I will give you is at our own hospital, we're heavily using artificial intelligence these days, and you need real-time data. And some people will say, well, that's cute research. And I'll say it's research that can save lives, because we actually have an algorithm that's been deployed for over a year now that predicts at least 24 hours in advance when patients will die or go to the ICU. And the way we've actually approached it is we've said we built models. That's been a bit of a research function, yes, but we need to deploy the models to get research into translation. But if you're telling me that I can't have access to identified data and I can't tell you who's going to be at risk, it kind of defeats the purpose, doesn't it? So we've been able to figure out how to meld those two worlds. We've deployed the algorithm for over a year now, and our preliminary data are suggesting at least a 15-20% reduction in mortality. So if we enable this sort of ability to be able to use data, to be able to drive it into clinical practice, I think it's going to have massive benefits for society at large, to the point where we'll be providing more effective care, helping patients live longer and enjoy life more. So there's benefits to society, as well as the research community, as well as the patient care community.
Thanks, Mohammed.
Katie, do you want to go?
You know, I'll say briefly that, you know, I think the notion of data portability or data mobility is a helpful one, and it's really, you know, to Ewan's point around patient-centric data architecture versus custodial-centered data architecture. If we really think of patients as the owners of their own data, and you set up the right sort of consent management standards, then a lot can flow from there, and you're doing the sharing while respecting the privacy in a fairly straightforward way.
Yeah, and I'll just add to that. I think one of the fundamental problems is we failed in Canada to articulate problem, and the three of us have just done. We're getting there, and it's a benefit of COVID that it has raised the attention to this issue. So because there's a lack of literacy around the implications of the harm that is arising from our lack of capacity to use data. And so it's quite shocking in a way in Canada that we lack a coherent legislated approach to the proactive use of data that benefits citizens of Canada. It's largely absent. How did we get to this space? The manner in which we have architected data is damaging people, both on an individual and population basis. And most people don't know it. Most legislators don't know it. They don't understand, people don't understand that the custodial model is a model that worked well in an analog world, but does not work well in this model. So we need to articulate that and allow ourselves to be more literate about the problem at hand, what is ailing. That what has happened is akin to a healthcare provider. Someone walks in, you don't ask them what their problem is, you just give them a drug. Because that's the drug we always gave, but that's not the problem. So the second point is this, Michael, and you and I have worked together with Mohammed intimately on these issues and long discussions at the Pan-Canadian Health Data Strategy. The problem largely in Canada, I think the issues with privacy and privacy commissioners have a bad name, and it's unfortunate. I don't believe the issue is with the privacy legislation. The issue is that the legislation or the public policy needed to promote the use of data is missing. So the privacy approach to privacy is there's no balance. And so we have to get over this notion that there's something bad about the approach to privacy. What's bad is there is no approach to proactive, safe use of data that will balance the our approach to privacy.
Maybe I'll just also just add to Ewan's point. When we were actually creating the environment at our end, there were people who were telling us, you can't do this, the legislation won't allow you. And often these are folks who don't understand the legislation, but they're magically given authority to make decisions. And to Ewan's point, I think that's bang on. We need a mechanism to educate, to empower and enable data to be used to its maximum potential.
And I'll just add, I have been in boardrooms for 30 years at senior levels across Canada talking about informatics. Not to be disrespectful, the problem we face has not been framed in a manner that articulates the strategic approach, which has been fragmented, regionalized, custodialized, which is a new word that I've just invented, and no one is articulating what the problem is, and we are damaging ourselves very, very effectively. The healthcare system is doing exactly what it is designed not to do, and that is damage Canadians through misuse of information, and that has not been articulated.
So thank you very much. We are out of time. I'll just say in closing that, and also seeing what David O'Toole is writing just now in the chat is relevant here. That as a privacy commissioner, I can say we're regularly frustrated when we hear tales of people saying we can't share data, we can't disclose this data because it is inconsistent with privacy legislation. And we often will, as privacy commissioners, say, where is that in the legislation that says that you can't share that? Very commonly, it's an overly conservative approach taken from a risk-averse nature, and there are reasons why this happens. But because, and I think as David O'Toole is suggesting in the chat right now, there's no, and as Ewan has suggested, there's no proactive positive imperative. It's not established in the purpose of the legislation that the sections of the legislation be highlighted and said, we need to use this data. This is, I think, the interpretive layer that David is talking about. And this really gets to the heart of the shift from custodianship to stewardship. That is a big thrust of the EAG and what Vivek started this conference by talking about. I will, so we're about to lose things here now, and the next session is about to start. So I do want to recognize one of the questions that was submitted in advance, which said, well, what about all the social determinants of health data and all that data? How are we going to fit that in with all of this health data? Wow. I'm glad we don't have any more time to talk about that, because we'd never be able to solve that problem today, but it is certainly the next frontier. But so just saying that, I want to say thank you very much to you and Katie, Mohammed, and the organizers of this conference for this opportunity to talk to you today.
Thank you.
Thank you,
Thank
everyone.
you. Take care.